Murali, we'll start.
Sir, okay, sir, we can start, sir.
Good evening to one and all. This is Dr. Sumaran. I'm the Dean and Director of Sri Ramakrishna Hospital, Coimbatore. On behalf of the management of Sri Ramakrishna Hospital, I welcome our senior consultants and from the city of Coimbatore, doctors and postgraduates who have joined us in this webinar. I welcome all of you. And today's speakers are Dr. G. Madhushankar with MD DM nephrology from All India Institute of Medical Sciences. And he has had his fellowship in clinical hypertension from the University of Toronto. And he is going to talk about diabetes, hypertension, and kidney disease, all interrelated problems. And he is going to highlight us with problems of diabetes and hypertension on kidneys. And the next speaker is Dr. Ganesh Prasad. He is a dynamic urologist with MS General Surgery, MRCS Edinburgh, and MCS Urology. And he is going to talk about the recent advances in kidney stone management. I welcome both the speakers, and I thank them for accepting our invitation to talk on their topics today. And I welcome Dr. Madhushankar to take over the stage. Thank you.
Good evening, one and all. Thank you, sir, for the warm introduction. Yes, I'll share my presentation and we can get ahead with the topic that I'll be discussing with you for the next 20-25 minutes maybe. So, good evening, everyone, once again. I hope at the end of it, I would have made your time a little more useful from whatever I'm going to share with you right now. We celebrate second Thursday of every March as the World Kidney Day, and theme is projected every year. It is like it varies on an yearly basis, and this year the theme that we have chosen that is chosen by the International Society of Nephrology is the kidney health for all. And the crux is to bridge the knowledge gap for a better kidney care. The reason being the kidney diseases, acute or chronic, is on the rise, and it is increasing in incidence and prevalence on a daily basis. But there is a huge gap between the sort of knowledge that we have, and there is lots of space that has to be bridged, that is at the level of healthcare providers, at the level of community, and even at the level of decision makers. So that is the reason the International Society came up with this theme for this year. So focusing particularly on chronic kidney diseases, we call some renal dysfunction to be chronic when the GFR, that is the glomerular filtration rate, is less than 60 mL per minute, and the duration is 3 months or more than that. Anything that is less than 3 months can be an acute kidney injury or an acute kidney disease, and that again depends upon the duration. It is expected that 1 in 10 adults worldwide can suffer from a chronic kidney disease in the future. It's increasing in incidence and prevalence to the extent that from the 12th leading cause of mortality, CKD is projected to be the 5th leading cause of mortality by 2040, which is not so far away, just another 2 decades or so. Well, the question that we commonly come across is how to have a healthy kidneys. How can I keep my kidneys healthy? Now, the secret is very simple. It is nothing like, it is not magic, you know, that is the secret ingredient in the soup that is served in the Kung Fu Panda movie. The leading cause for the chronic kidney disease is diabetes and hypertension, and having those two diseases under check is the key behind having a healthy kidney disease. You know, healthy kidneys. You know, there is an increase in incidence of lifestyle diseases. The diseases that was once thought to be of disease of plenty or disease of resourceful people. Now this is affecting almost all strata, irrespective of their economic status and irrespective of the age. What we thought would be occurring at the fourth or fifth decade is commonly seen in the second and third decade, and there is increasing prevalence as days and years pass by. Like lifestyle diseases like diabetes, hypertension, obesity, renal calculus disease, and coronary artery disease, which we collectively call as metabolic syndrome, they commonly fall under this umbrella of lifestyle diseases, which is because of genetic predisposition, very unhealthy eating habits, and lack of proper physical activity. Oh, now diabetes, world over, by 2040, around 642 million people is projected to suffer from diabetes, which is as much as 8% of the global population. Now, the renal involvement in diabetes can be to the tune of 30 to 40%, and it keeps on increasing. Type 1 can have 20 to 30% renal involvement, and type 2 can have 30 to 40%. Diabetes was first described in 1552, and it took nearly 3 millennium to have a solid or to confirm a solid association between diabetes and kidneys. That is, diabetes causing a chronic kidney disease. It took nearly 3 millennium from the time it was first described. And ever since that association was proven to be a causation, it just took 3 decades for diabetes to take over any etiology to be the leading cause for chronic kidney diseases. And within a span of 20-25 diseases, the deaths because of diabetic kidney disease increased by a whopping 94%. It more than doubled literally. And to diagnose a diabetic kidney disease, it is more of clinical and laboratory. Not every time do we do a biopsy and a histopathological confirmation. The simple definition is an increase in proteinuria, urine albumin creatinine ratio of more than 30, and a reduction in glomerular filtration rate of less than 60 mL, which is done twice, 3 months apart. But then there are lots of caveats in the above definition for a diabetic kidney disease, because 20% can have a diabetic kidney disease without proteinuria. So if you just depend upon proteinuria as a marker or as a definition, you can go wrong in as much percentage. Around 15 to 20% of pre-diabetics can have microalbuminuria, which means you might be detecting proteinuria in them, but in blood they may not have the sugar or a HbA1c criteria to meet diabetes. Still, a biopsy will prove a diabetic kidney disease in them, which is perplexing. To do a kidney biopsy to prove diabetes it's beyond imagination. And a good subset can have a combination of diabetic and non-diabetic kidney diseases. An atypical feature like a sudden onset of decline in EGFR or a very rapidly declining EGFR, an abrupt increase in proteinuria, or proteinuria which was once stable, which is very rapidly increasing to develop a nephritic or a nephrotic picture, an active urine with hematuria, red cell cast, refractory hypertension, any signs and symptoms of any other systemic disease other than diabetes, let's say for example a rheumatoid arthritis or a systemic lupus, or a more than 30% decline in glomerular filtration rate within 2 to 3 months of starting a RAS blocker, an AC or ARB. These are all supposed to be the atypical features to suspect a non-diabetic kidney disease in someone suffering from diabetes and renal involvement. The natural history, as per Mogensen's, is very classically suited for a type 1 diabetes. We do not come across this classic progression of an increase in GFR followed by a gradual increase in proteinuria, which becomes an incipient and overt nephropathy from a span of detection to 20-25 years, which is not commonly seen these days. This was described when the diabetes and renal association was first described, and it is more commonly seen with type 1 diabetes. So the leading question or the food for thought is, do we consider all renal failure in diabetics secondary to a diabetic kidney disease? That is not the case, as I just said. Even if you go by the definition, there is a good chance that you may miss certain non-diabetic kidney diseases. And the incidence of non-diabetics in diabetic is anywhere between 12 to 80%. And that depends upon how true or what is your indication for a biopsy. That varies from center to center. Where the biopsy is very common, you can find increased non-diabetic kidney disease. where the biopsy is more conservative, you can the chances of non-diabetic kidney diseases are on the lesser side. It is immaterial whether you have a diabetic retinopathy or not, or diabetic nephropathy, neuropathy or not, or even whether the presence of hematuria or red cell cast. I'll quickly go by the history. I'll just rush through. This is an elderly female with a known long-standing diabetes, hypertension, and hypothyroidism, who presented to us with an advanced renal dysfunction. And she came, the creatinine was 5.6 with an active urine with plenty of RBCs, WBCs, and proteinuria. Now, considering the way the creatinine progressed with duration of illness of over 7 to 10 days of abdominal discomfort and an active urine, our first differential was a non-diabetic kidney disease, because this classically suits into an atypical feature of suspecting non-diabetic. So she was on clopidogrel, which we stopped, and then subsequently the creatinine, which was 5.6, progressed to 6.9 the very next day. Viral screening and autoimmune screening were negative. So going by clinical suspicion with a strong lenience towards a non-diabetic glomerulonephritis, we started her on methylprednisone pulses, and we did a biopsy, which to our surprise came as an anti-glomerular basement membrane disease. One, this is very rare, and number two, that to have a background of diabetes is not commonly described. So we aggressively treated her with plasma exchanges and cyclophosphamide with a good sugar control. The titer was also on the higher side. With continuing plasma exchanges, her titer came down, creatinine came down, and now she is following up with a creatinine of 1.1. What effectively would have become a dialysis dependent state, now she is leading a normal renal status. Now, the beauty of this case is not every GBM responds, because anti-GBM is known to be one of the most aggressive form of glomerulonephritis, with presentation creatinine of more than 5, leading to dialysis in most of the cases, with the background of diabetes particularly. This lady was lucky enough, and she gave us enough opportunity to bring her back to a normal renal status. Now, another elderly gentleman with a long-standing diabetes, hypertension, with diabetic retinopathy and neuropathy, again came with a reasonably sudden onset of proteinuria, which was apparently normal a few months ago. Now, he developed fetal edema, which he claims he did not have in the past. So we presume this is a sudden onset of proteinuria, which is unlikely to be due to diabetes. Although he had all the classical features of diabetic kidney disease, age, duration, diabetic retinopathy, and neuropathy, we still went by our instinct of non-diabetic. And a biopsy in him turned out to be a primary amyloidosis, with further proven by blood investigations to have multiple myeloma. This gentleman was started on chemotherapy, and he did extremely well. His proteinuria subsided, and he's in remission of multiple myeloma. So these are just a couple of scenarios where suspicion gives us a diagnosis, and what could have been another run-of-the-mill diabetic kidney disease turned out to be interesting, which benefited patient and which also enriched our knowledge. So I went on to collect a few patients from our hospital. So far it is 42, with the list growing on a frequent basis. Now, as we all expect, the male gender has a more incidence of diabetic and a non-diabetic kidney disease. Now, going by the incidence of diabetic retinopathy, it is seen both in those with diabetic kidney disease as well as non-diabetic kidney disease. There is no statistical significance of diabetic retinopathy helping us make a diagnosis of a diabetic or a non-diabetic kidney disease. So is the presence of hematuria and red cell cast. So the bottom line is, irrespective, as a routine part of screening on an OPD basis, whether the patient has a hematuria or a red cell cast or a diabetic retinopathy, it could be either a diabetic or a non-diabetic kidney disease. There is no statistical significance between both classes as proven by biopsy. The only difference that I found in this observation was duration of diabetes. The more the duration, the more the chances that it is likely to be a diabetic kidney disease. And in this observation, the duration was 10 years. And most of the study says it is 12 years or more. So the main difference here is the duration of diabetes. If it is between 5 to 10 years, the chances of having non-diabetic was more. But the beauty is treating them leads to a decline in creatinine on the follow-up, which adds multiple meaningful years to their life. The most common non-diabetic kidney disease we found in diabetics was membranous nephropathy. And those with the diabetic kidney disease had a duration of diabetes of more than 10 years, and invariably their creatinine progressed on follow-up. So what to do as a primary contact physician, how and when to screen for a diabetic kidney disease. They classically say that for a type 1 diabetes, we should start screening with serum creatinine and urine albumin creatinine ratio 5 years after the diagnosis and then annually thereafter. But then the screening should start after 1 year in those who have poor diabetic control, in those who have a high blood pressure, whose lipids are high, and whose diabetes onset is after puberty. And then it should continue annually thereafter. For a type 2 diabetes, there is a good chance that around 20 to 30% can have a renal involvement at the time of diagnosis of diabetes. So it is imperative that we screen them at diagnosis and then annually thereafter. So the bottom line here is not every renal involvement in a diabetic is because of diabetic kidney disease. Where suspicious and where indicated, it is necessary that we think of a non-diabetic and do a biopsy or a blood investigation judicially, because that will significantly alter the prognosis in the short term as well as in the long term. Going on with a short discussion about hypertension. We know hypertension is the pressure that is exerted by the blood on the walls of the vessels. It's never linear. We'd never have a stable blood pressure. It just fluctuates on a second and minute basis based upon the activity, a lot of other factors, and it has its own circadian rhythm. The point here is the baseline. Although various hypertension bodies have a definition to define hypertension, it's 120, 80, 140, 90. What is much more pragmatic is how much difference or how much it differs from the baseline. Let's say someone has a baseline of 110 and an increase of 20 millimeters of systolic to 130 would still be considered as normal or pre-hypertensive. But still an increase of 20 millimeters of systolic and 10 millimeters of diastolic doubles the cardiovascular, renal, and cerebrovascular complications. So according to me, the definition is any level at which the treatment outweighs the risks of treating the patient. Reducing the blood pressure number needed to treat to bring down the target organ damage should be considered as hypertension, and going very strictly by the textbook definition does not help in every case. And as we know, the incidence and the prevalence of hypertension is also increasing, and it is like a vicious cycle. Of both systolic and diastolic, it is the systolic BP that is closely correlated with the target organ damage. And an increase in pressure leads to an increase in target organ damage, and that further worsens the blood pressure control, which further increases the target organs that are damaged in the short and the long run. There is a special mention about salt, which I have a very personal liking about. The word salary, that comes from the word which effectively means salarium, which is nothing but a part of the salary. Such was the heritage, or such was the history, such that during the olden times, salt was used as a currency. It was used as a exchange between communities. If you want to get something, you could use salt in exchange. And Roman soldiers were paid, the part of their salary was given as a salt. Such was the rarity of the salt. And as time went by, it became a common commodity. It just became a common salt, just like a common man, army, right? We are talking about elites, but salt was so rare, and then history changed. Chocolates became the commodity exchange, and then leather, and then coins, gold. So why it gains importance is salt is the underlying culprit for most causes of increased in blood pressure, which leads to target organ damages. Now, classifying hypertension, it's most of the cases it is primary, which is as common as 70 to 80%. But then a good 20 to 30% can be secondary to a renal parenchymal cause, the most common, followed by renovascular and endocrine related. And aldosterone excess is common in 14% of endocrine causes of hypertension, which ranks third. And then vascular, which can be in small vessel or large vessel diseases. Well, there are a few cases where if we go by convention, we could miss. Just an example. This is a 36-year-old lady who was on treatment for hypertension for 5 years with a calcium channel blocker and beta blocker on and off and switching the physicians and switching the medications and non-compliant. She suddenly presented to ICU with a flaccid paralysis of all four limbs, and associated with it, the only lead was hypokalemia. Now she was treated, considered like diagnosed as a myopathy or hypokalemic paralysis. Ultimately, what turned out is it is cause of aldosterone excess. It is just connecting the dots, hypertension with hypokalemia. There has to be an increased renin or an aldosterone. So, which can be either a renovascular or an increased aldosterone due to any cause. So, we did a renin aldosterone ratio, which was excessive. We started around aldosterone antagonist, and then everything went normal. Her pressures were brought under control. She never came to us with another episode of hypokalemia. And then another young girl who presented with seizures and a blood pressure of around 220 systolic. And the only lead we could get was an increase in ESR. So further digging the history and further investigations, we found that she had a vasculitis involving the renal vasculature. The entire right renal artery was stenosed, and she had collaterals established. Now she never had a bruit because it was a tight stenosis. The entire vasculature was thrombosed. So this is when we uh, dig and when we look and when we investigate, we will eventually land up with rare causes. This young lady was treated with steroids and azathioprine and antiplatelet and anticoagulants, and she became normal. Again, this is the classification and the definition that I was talking about. What matters is what is the level at which a person is expected to have target organ damage, and what is the benefit we will gain or we will give him by treating him as against the risk of treating him. All said and done, in most cases of CKD, irrespective of the target of defining, the target control is the same, which is around 130 to 80. And what we should remember, which we don't commonly remember, is how to measure our blood pressure. What are the precautions we should take? Because there are a good subset of patients who tell us that the pressures are high only in the hospital, and when they measure it somewhere at their home or elsewhere, it is normal. Before we take their words for granted, it is the way that we measure that we should reassess. Do we use the proper size cuff? Do we make him sit in a chair with his back rested, with his feet on the ground, with the arm at the level of the heart? And there are at least 7 different checkpoints. We should not engage him in a conversation during the measurement, and his bladder should be empty. So even despite that, somebody would say that I had a blood pressure, I was given medication, and now it is under control and I'm not taking it. If you still have a doubt, it is better to do multiple office measurements or out of office measurements, which are much more physiological, like a home-based BP measurement or an ambulatory BP measurement. So the biggest challenge that we are facing in treating hypertension is denial. They once or twice the measured pressures are high, we start them on pills, then the pressure goes down, and then there is a belief that with some native medication or some dietary habits or the latest fad is bottle gourd or some sort of a soup from different plant which will bring down the blood pressure. So they stop the medications on their own and come at a later time to us or to someone else with extensive target organ damage like renal dysfunction or a stroke with a bleed or acute coronary event. So it is that denial which you are finding it difficult to treat, not any other cause for hypertension. So coming back to the theme, which is kidney health for all, how to have healthy kidneys. It is nothing, it's no magic there. It is what we have been taught from time immemorial and what we actually stopped following. Mindful eating with a proper proportion diet, adequate, the food pyramid with the base of carbohydrate and then protein and fat and micronutrients, and exercise of at least 150 minutes a week with adequate water intake. The general belief is drinking too much is going to flush out the toxins. There is no scientific basis to it, and not drinking too much because of work or environmental thing is also not good. Monitoring for lifestyle diseases like diabetes, hypertension, being compliant, following up for target organ damage, and avoiding tobacco. That is how we maintain a healthy kidneys, and this is the perfect recipe for it. The healthy kidneys are nothing but a product of healthy lifestyle, and there is a huge gap among the healthcare policy makers, healthcare providers, and community regarding kidney health, and that is where we have to work upon. And that is my end. Thank you everyone for patient listening. And now our urologist, Dr. Ganesh Prasad, will take over the session. Thank you so much.
Respected Dean Sir, senior consultants, and my dear colleagues, I am here to tell a few words about the recent advances in kidney stone management. Today's learning objectives are we are going to have a new insight into the causes of renal stones, diagnosis and medical management, what are all the recent advances, and how is laser useful in stone disease, followed by what is important in follow-up and what is new in the metabolic workup. When life gives you a lemon, make a lemonade. And when life gives you a stone, make a citadel. So here is a video of a huge staghorn calculus in kidney, which is being broken. You can have a look at the stone burden, the volume of the stone, and the amount of energy being used to break the stone. On the background, you can very well have an idea how much amount of damage it will have caused to the nephrons. And we have to break the stone continuously for 3 hours to give a complete stone clearance. And all these are possible because of the state-of-art equipments which are available in our own hospital. This is a renal calculus, and we use here a holmium laser to melt the renal stone. These are just for introduction. You can see how the holmium laser has bursted a stone within minutes. Now let's go back to basics. The presentation is very common, as most of you know. The loin pain is the most common way of presentation. If it is radiating from loin to groin, then the chance of having a ureteric stone is more rather than a kidney stone. These are the type of renal stones. It may be an oxalate stone, phosphate, a uric acid, and cysteine, 4 common varieties. The other name of oxalate stone is mulberry stone. Since they have sharp edges, there is high chance that they may tear the ureter or kidney or bladder, and there is a high chance of hematuria. Phosphate stones accompany infection, urinary infection, seen commonly in females with recurrent UTI. And a variant of phosphate stone is calcium, ammonium, and magnesium phosphate, commonly seen in alkaline urine. Stone enlarges rapidly and takes the shape of all calyces. That is to show how a staghorn calculus looks. The third variant is a uric acid calculus, seen commonly in people who consume a lot of protein and who have gout. The stones are very soft, smooth, multiple. Characteristic feature of a uric acid stone is many a times we have only X-ray at peripheral level hospital. It is commonly missed in an X-ray. If you do an X-ray, you can't find a stone, but the stone is still there. Can be made up with a USG or with a CT scan. Cysteine stones are extremely rare, not that common. It's an autosomal recessive disorder, cystinuria, where we get cysteine stones. Investigation-wise, ultrasound is very much useful, which is very much available in most of the primary, tertiary, and peripheral centers. X-ray KUB will give an idea in primary healthcare centers. An intravenous urogram was the main investigation before few years, but after the invent of CT and after CT has come with very little radiation, a plain CT scan is the investigation of choice. Excuse me. What is new here in intravenous urogram? Now that for past few years we are using X-rays with minimal penetration, minimal radiation damage, and we use low osmolar contrast medium so that the chance of having anaphylaxis, bronchial asthma, and wheeze are very much reduced with this low osmolar contrast medium. That's a typical picture of intravenous urogram. On the left side, you can see the system is dilated because of ureteric obstruction by a stone. Investigation of choice is always a CT abdomen. In CT abdomen, you can pick up 99% of stones. It's highly sensitive and highly specific for ureteric stones and renal stones. Now, the question arises, most of general practitioners ask this question to me. So, what is the indication of medical expulsive therapy? When we can go for medical expulsive therapy? Initially, how to manage the ureteric colic? That's also element of debate, because many a times these people are being given non-steroidal anti-inflammatory medications continuously by a consultant number 1, 2, 3. They walk into different clinics and get shots of non-steroidal anti-inflammatory drugs. And by the time they land up in our hospital, their creatinine level is really high. NSAID-induced renal damage already happens. So I advise better to give a single shot of NSAID, and if possible, you can start with paracetamol, IV paracetamol injection. The antiemetic Emicet, ondansetron, is a drug of choice. And alpha blockers are very much useful if the stone is at the level of lower ureter. The alpha blockers like tamsulosin, which has been used for prostatic enlargement, silodosin, which is a recent alpha blocker, are extremely useful. They relax the lower ureter and they help in pushing the stone out. Whereas if the stone is in the upper ureter, they are of little use. Now, what is the size criteria when to say, okay, this can be managed medically? Usually the size criteria is, if it is a 4 millimeter stone, there is 80% chance that you may pass it spontaneously. 4 millimeter to 8 millimeter is a gray zone. It may be this way or that way. If it is more than 8 millimeter, then there is only a 10 to 20% chance of passing out the stone. 80% of time it doesn't come out. Now, what are the surgical options for treating a ureteric stone? So we have ureteroscopy, lithotripsy, and laser lithotripsy. The one which is present down is a semi-rigid ureteroscope, which is commonly used everywhere. The one which is present up is a flexible ureteroscope. The flexible ureteroscope has the added advantage of clearing stones in the ureter, and it can also clear the stone inside the kidney. Because it is flexible, it can reach even the calyces of the kidney. So to fragment the stone, we have a pneumatic lithoclast, which is called Swiss lithoclast, state-of-art equipment. We have laser, the form of HOLMIUM YAG laser, a very precise laser which has high intensity light amplified waves which help in breaking the stone, but at the same time tissue penetration is very less, and we have an ultrasonic lithotripsy too. The baskets are commonly used in retrieving the stones. I show here a video where we use these baskets to retrieve the stone in the ureter, and that is a ureteric stone which is present at the level of upper ureter. Basket is deployed in. You can see the stone is being held with the basket so that it is not pushed back into the kidney. Just to stabilize the stone at the level of upper ureter, we use basket there. The stone is caught in the basket there. And now the lithotripsy starts. The stone is fragmented completely into smaller fragments. And the role of basket doesn't end there. We use the basket to retrieve the stones too. We bring the stones down with the help of basket. You can see the fragments are slowly pulled down with the help of basket, Nitilal basket. These are ureteric stents. Many of dental practitioners might be aware of the ureteric stents. Unlike the stents which are placed in the heart which stay forever, the stents which are placed in ureter should be removed definitely. If it is not removed, then it itself turns into a stone and it may produce other problems. It may even go to produce renal failure. So the ureteric stents are of various sizes. Depending on the patient's height, we choose the size of the ureteric stent. If it is going to be a polyurethane stent which is commonly used, the upper limit is it can't be kept inside for 3 months. A very important information which I would like to pass on to most of the practitioners. If you see somebody with a ureteric stent, please advise him to visit his urologist to get it removed at the right time. Many a times people get the surgery done, they get the stone cleared. The purpose of placing it inside is to drain the urine for a short time because there is so much of edema around the stone. So this edema keeps being there and it remains there. If you place a stent inside, this helps in draining the urine or pus, whichever is present there. And sometimes the small fragments which are there during the time of lithotripsy, small fragments are formed and these fragments come out by the side of the stent. So it helps in the fragments getting evacuated out. So stent is naturally placed almost in all cases after the ureteric surgery or renal surgery. And it's a duty of every referring practitioner to put a word to the patient to come back to us to remove the stent, which is a very simple outpatient procedure. They have to walk in, a 10-minute procedure, we'll remove the stent and make them comfortable. The time period is for polyurethane stents, it's only 3 months. If it is going to be a silicone stent, we place silicone stents in people with cancer. If it is an ovarian malignancy or a CA cervix, we place silicone stents inside so that the renal parameters will come back to normal, urine will drain normally, they will go for chemotherapy, and after chemotherapy they will come back for stent exchange. That can stay inside even for 12 months. That is a typical X-ray which shows stent in position. The upper end of J is inside the kidney and lower end is in the urinary bladder. Sometimes what happens is the presentation of the patient is very late. This patient is a very young female who actually did an ultrasound before 1 year which showed a lower ureteric stone. She ignored the stone and you can see there is so much of edema around the stone. There is a lot of tissue and edema which is almost closing the stone. Even in such cases, using a HOLMIUM laser, which is a state-of-art laser, will give complete stone clearance and we were able to clear the stone completely. You can see that even the tissues can be bursted and removed away by the HOLMIUM laser. But at the same time, the penetration of HOLMIUM laser is only 5 mm. So the tissues which are not in contact with the laser doesn't get damaged. So that the stone is continuously being broken with HOLMIUM laser. Since the patient presented very late, See, there is so much of difficulty there. There is so much of edema and tissue involved there. This is the final picture. You can see I have gone into the proximal ureter after clearing the stone, and I will show you what kind of damage the stone staying there for long duration has created. The entire area needs to be healed completely, and it will take a long time. So we have planned to place a stent inside for 2 to 3 months for this patient to allow that area to heal completely. Now let's move on to management of renal stones. One simple treatment for renal stones which are less than 1 centimeter is doing a extracorporeal shock wave lithotripsy. The waves which arise from this machine definitely can break stones which are less than 1 centimeter. It may require 1 or 2 sitting. It's a simple outpatient procedure. Patient need not get admitted. They can walk in and walk out. It may use an electrohydraulic energy source or electromagnetic energy source or a piezoelectric energy source. Previously, before 25-30 years, open surgery was a standard of choice for huge renal stones. And you can imagine the amount of scar which open surgery can have on the patients. The right side, you have the scar because of open renal surgery. But now, the treatment of choice is percutaneous nephrolithotripsy, which is a keyhole surgery. And you can see the scar on the left side, a very small scar in a patient with a huge stone. So using this keyhole surgical technique called PCNL, percutaneous nephrolithotripsy, we place an endoscopic instrument inside the kidney, visualize the stone, break the stone into small fragments completely, and remove the stone. And this is indicated in people who have stone which is more than 1.5 centimeter to 2 centimeter. Once again, a pictogram showing percutaneous nephrolithotripsy. So this is the intraoperative picture of kidney. After reaching into the kidney, this is the picture. You can see the stone being broken there. And that is a ureteric catheter which is into the kidney. So here we use either laser or pneumatic energy. Pneumatic energy is nothing but the air which is converted into mechanical energy. The normal air, atmospheric air, is converted into forceful mechanical energy, and we break the stone, retrieve the stone completely using a grasper. So the next choice is, people are asking for scarless surgery. No, they don't want that keyhole surgery scar also. They want a complete stone clearance even without scar. So the treatment of choice in such occasions is retrograde intrarenal surgery, the so-called RIRS, where we use a flexible ureteroscope into the kidney. That's a flexible ureteroscope which is available in our hospital. We use it to access the kidney and remove the stone. The flexible ureteroscope has a very narrow diameter, 6 to 7 French. You can see how it goes into the kidney. This is a pictographic representation, animated representation of how it catches hold of the lower calyceal stone. We can take the stone and bring it to a comfortable location. We can bring it to the renal pelvis, place it there, and break using the laser energy source. And the broken fragments are retrieved outside using the same basket, slowly, one by one. Now this is animated version. I will show the true picture, what we do. This is our recorded video, and this is the internal appearance of kidney. You can see the calyces there, different calyces, and the stone inside one of the calyx. You can see the respiratory movement of the patient. While doing the procedure, patient's respiratory movements are there. The breathing movements move the kidneys down. So it's not stable, it keeps moving there. And we have to be very careful that the laser touches only the stone and breaks only the stone. You can see the laser punching the stone there. And with this technology, we will be able to give a complete stone clearance Very important thing, after clearing the stone, we have to find out what is the reason this particular patient is having a stone. That will prevent further stone occurrence, because the chance of having a recurrent stone disease within 5-year time is 50%. So we have to do a proper metabolic workup after clearing the stone completely. And what are the indications of doing a metabolic workup? It is very important in people who are going to get recurrent stone disease. There is going to be a strong family history. If there is some pathology, bony pathology, underlying pathology in them, and people who are having recurrent urinary tract infection, if there is going to be only one kidney, we have to take care of the kidney, do a proper metabolic workup. And if there are different kind of stones like uric acid stone, the suspicion, if you take a fragment and send it out, it comes as uric acid stone, then we need to do a proper metabolic workup. What does metabolic workup means? So very simple, we have to, there are two versions. One is a complete metabolic workup where we do blood investigations and 24-hour urine collection, and then we investigate it for further thing. We also have a simplified workup where we look only for the pH of urine, urine culture, we do a nitroprusside test. So if the pH is going to be acidic, there is high chance of uric acid stone. But it's going to be alkaline, there is a high chance of infection stone. That is the appearance of various types of urinary calculi. So 24-hour urine is collected. So there are so many components which we look for. To make it things very simple, I will say 4 important things which we have to look in the 24-hour urine is, one is citric acid, citrate. If the citric acid is going to be less, then there is a very high chance of urine stone formation. Calcium, oxalate. If the calcium and oxalate are going to be more in the 24-hour urine than the permissible limits, then there is high chance of stone formation. And finally, phosphate and uric acid, which can also be more in people with stone disease. So what are all the interventions in different types of stone? Then the commonly asked question among general practitioners and commonly patients who attend our OP is, can I take Pepsi, Coke and all these carbonated beverages? No, these carbonated beverages are prone to produce stone disease. Very high chance of getting stone disease. Taking green tea contains lot of oxalate. It is good for reducing weight and other purpose, but taking 4 or 5 cups of green tea daily increases the chance of stone formation. In vegetarian diet, almost all vegetarian diet have high amount of fiber. So taking vegetarian diet always prevents the person from getting stone. But one important thing is, if you take lot of lettuce and spinach, having spinach increases the amount of oxalate in the urine. Sometimes it may predispose somebody to stone formation. Then what kind of fruits one can take? Almost all fruits are helpful in preventing stone, but for 2. One is grapes. So grapes has high amount of oxalate, and sapota, commonly taken, sapota chiku, that has high amount of oxalate. So better to prevent these 2 things. And apart from that, if a patient is going to be obese, you have to ask them to have a healthy lifestyle and reduce obesity, because the chance of having uric acid stone and other type of stone is very high. The dietary recommendations, certain people, especially elderly females, are prescribed calcium tablets commonly to prevent osteoporosis. If there is an episode of stone formation, then better to avoid these tablets, because the chance of stone formation is high. Vitamin D supplementations without any indication also may predispose to stone formation. And most important thing of all this is high sodium diet. Lot of salt taken internally in the form of non-vegetarian diet, or it can be in the form of papad, it can be in the form of pickles, it can be in the form of dried fish, whatever form. If sodium is going to be taken in a large amount, there are sodium calcium channels internally. So a lot of calcium gets absorbed inside and ultimately leads to calcium oxalate stone formation. So taking citric acid in the form of lemon and lime prevents stone formation. Now what are all the medical therapy? If the patient is going to excrete lot of calcium in the urine, then the prescribed treatment of choice is the diuretic hydrochlorothiazide. So thiazide diuretics prevents hypercalciuria and may prevent stone formation. The other thing is sodium cellulose phosphate. So sodium cellulose phosphate, getting it is very rare and very difficult, whereas thiazide diuretics are easily available. So if there is an indication, we can start on thiazide diuretics. The second one is potassium citrate. Potassium citrate taken orally prevents stone formation in hypercalciuria. Very rarely orthophosphate is also used. In people with hyperoxaluria, there are two types, type 1 and type 2. Taking simple vitamin B, pyridoxine vitamin, prevents stone formation. Uric acid stones, we prescribe allopurinol or febuxostat. Both will reduce the uric acid level and prevent stone formation. For struvite stones are staghorn stones which are formed because of urinary infection. We have to control the infection. And medications, apart from infection, acetohydroxyamic acid is a medication which is used to reduce the struvite stones. Cystine stones are very rare. I don't want to get into that. So to summarize things, the recently available techniques actually help us in achieving stone clearance by minimally invasive procedures. We have instruments to do keyhole surgery. We have instruments also in our hospital to do totally scarless surgery. State-of-art equipments are available with us. So you can make use of all these instruments and give a better life for the patients at the earliest. If the patients are going to present in a delayed manner with bilateral ureteric stone or a huge ureteric stone with a high stone burden, then it's a problem both for patient and doctors. Thank you for listening patiently. Any questions?
Thank you, Dr. Ganesh Prasad and Dr. Madhushankar. Any questions from the audience and for any interaction is welcome.
If there are no questions, thanks for the opportunity. I thank our Dean sir for giving this opportunity, and I'm happy to transform the information which I have here. And please spread awareness, create awareness among people, among public about renal problems and stone disease. Thank you.
Okay, thank you, Dr. Ganesh and Dr. Madhushankar. And on behalf of Sri Ramakrishna Hospital, I thank all the participants. Thank you, one and all. Murali, we'll end the session.